I will be presenting today in 3 different parts. First, we're going to talk about what is ALS. Then we'll talk about what caregiving looks like and how it's unique for ALS. And then we'll talk a little bit about the ALS Association and how we fit into it all. But that's why we're going to pause at the end of each section for questions. It is a lot of information. So please go ahead and type in your questions as soon as they pop into your mind, and I'll make sure we go ahead and pause to answer those. So as someone said, I work for the ALS Association. I'm specifically supporting our family caregivers, and that is something relatively new. So I'm very excited about this program. As you'll learn today, it's very necessary. So first, what is ALS? Well, it is at this point an always fatal neurodegenerative disease in which a person loses control over their muscles. So that brain is losing the connection to utilize the muscles, and therefore they begin to atrophy. They'll lose their ability to walk, talk, eat, and eventually breathe. Generally, this disease strikes between the ages of 40 and 70, but we know that's not always the case. Unfortunately, we do have clients who come to us in their 20s and 30s having a very early onset. So that is possible. There is no cure at this point, but we will talk about some of the treatments that can slow progression, though they do not halt the progression of ALS. So some quick facts: about 5,000 people are diagnosed every year. Once you are diagnosed, the average life expectancy is 2 to 5 years. But that being said, we do see people who progress much quicker and who may only live about 6 to 12 months from diagnosis. And then we have people who progress very slowly, who may live 10 to 15 years after diagnosis. Every case is so different and so unique. Every 90 minutes, someone is diagnosed with ALS and someone passes away from this disease. Now, only 10% of cases are actually inherited through genes. We call that familial ALS, but 90% of cases occur without family history, which is sporadic. Diagnosing ALS is extremely difficult. There is no one test or biomarker that allows a neurologist to say, this is most certainly ALS. Instead, the clinical exam involves a series of diagnostic tests that first need to rule out all other diseases that mimic ALS, which would be Parkinson's, PMD, PMA. These diagnostic tools that they're going to use to rule out other diseases include the EMG, nerve conduction velocity, blood and urine samples, a spinal tap, MRI, and then biopsies of the muscles and nerves. Because ALS is so difficult to diagnose, second opinions are always recommended. Unfortunately, we see sometimes that someone has had a knee replacement or a hip replacement before they get their diagnosis of ALS because they were initially misdiagnosed. More rarely, we'll see that people are diagnosed with ALS, and then after a few years of a neurologist watching the progression, that diagnosis may change. But like I said, that is very rare. This is why we always recommend second opinions as soon as you get the diagnosis, though. So I want to talk about the symptoms of ALS. This is a very progressive disease. So the initial symptoms are going to be small. You'll have some muscle weakness, probably involving arms or legs, speech or swallowing or breathing. ALS can present itself either initially in the limbs, so in a hand, in a foot, and that would be our limb onset, or it could be initially presenting in the throat, the mouth, and that would be a bulbar onset. So the initial symptoms could start pretty much anywhere, but as things progress, someone who initially notices symptoms in their hand will eventually start to have symptoms in other places of their body as well. Let's say you are initially having symptoms in your foot. You may be experiencing some unusual tripping. We call that drop foot. no matter where it's starting, you will experience some atrophy of the muscle tissue where those initial symptoms hit, some twitching, some cramping of those muscles. That happens especially in the hands and in the feet. If the symptoms are starting in the throat, you'll notice very thick speech, difficulty projecting your voice. So you may be getting quieter when you talk. In more advanced stages with that bulbar onset, you'll have a shortness of breath, difficulty in breathing and in swallowing. But like I said, these symptoms are progressive. So they'll start out really small. And, someone may think at first they're just tripping because they're getting clumsier. They're just dropping things because they're getting weaker. So these symptoms will start little and then they'll get increasingly more intrusive and difficult for the daily activities. And I want to go back and talk about treatment. So I said earlier that there is no treatment which halts ALS. There is no cure for this fatal disease at this point. With that being said, we've made more progress in the last 5 years than we have in the last 100 years. So we do have some drugs at this point, some treatments that will slow the progression. I'm going to talk a little bit about each of these, and then I'm going to pause for questions about ALS and everything we've talked about so far. One of the drugs that we have, one of the medications is Radicava. There's 2 ways to take this. There's Radicava infusion, which is an intravenous infusion. And then there's Radicava ORS, which is an oral dosage, a pill that you'll take, either orally or through a feeding tube. And with both of these versions, you're going to have an initial treatment cycle of 14 days, followed by a 14-day drug-free period, and then subsequent treatment cycles where you have 10 days of dosing, followed by 14 days of no medication. Radicava is covered by insurance, but this is where things get tricky because Radicava IV, the intravenous infusion, is covered by Medi-Cal Part B, while Radicava ORS is covered by Medicare Part D. D as in dog. So, we get a lot of questions about how expensive these drugs are. And the truth is that it's really important to work with your insurance company and make sure that you can get that coverage and that support. With Radicava, as with every other treatment I'm going to talk about, there are some adverse reactions. The most common for Radicava are confusion, gait disturbance, headache. And so some people are impacted enough by adverse reactions that they aren't able to take some of these treatments. The next one on our list is Riluzole. The brand name is Rilotech, but this is a tablet which you can take orally twice a day. This one you cannot take in a feeding tube. As I discussed with Radicava ORS, you can, right? So because Rilotech's version of Riluzole is not feeding tube friendly, we've got Tiglatic, which is thickened Riluzole, which can be taken when someone's having trouble swallowing thin liquids and when someone needs a feeding tube. So that's really important because of the ALS being such a progressive disease. We do know that at some point, many, many people experiencing ALS will have a feeding tube. And so it's important that these treatments are available to be administered that way. With both versions of Riluzole, of course, there are some side effects, some numbness, tingling around the mouth, some weakness, nausea, dizziness, decreased lung function. And so when there are side effects like that, and we already know the respiratory system can be affected by ALS, we do have people that need to weigh the risk and benefits of these drugs. And hopefully people are not experiencing that decreased lung function, but it does happen. And so these treatments are amazing, but it is so important to be working with your neurologist and your clinic team to make sure that that you're not experiencing any side effects that'll affect your overall quality of life. The next two treatments are really exciting to talk about. Relyvrio was just approved in September, and tofersen was just approved last week. So we are very excited to see that we're getting these new treatments on the market. First, we'll talk about Relyvrio. It's unique in the sense that it's a powder that you go ahead and you mix with water. It should be taken, the water mixed 8 ounces per packet, needs to be drinking within 1 hour of dissolving. For many people, it sounds like, oh, a glass of water in an hour, that's easy. But truthfully, with ALS, it can take quite a bit of time to drink that glass of water. It can really cause quite a bit of fatigue. You're using these muscles that are atrophying, if you are affected at that point in your throat. So for the first 3 weeks, that powder mix will be drinking 1 time a day. And then after that, it's going to be taken twice a day, which is 2 hours a day being spent on just trying to get this cup of water powder mixture down. At this point, the main side effects we're seeing with Relyvrio are some nausea, diarrhea, abdominal pain, some upper respiratory tract infection. Again, this is so different from person to person. One thing that people do experience is a really unpleasant taste with Relyvrio, to the extent that they, on their website, talk about different ways to minimize the taste of the drug. But I know they are working on that as we speak over at Relyvrio, trying to change that taste for us, make it a little bit easier. And then tofersen, which is our newest, is actually injected. It is actually injected in the back. So it's a little bit more difficult to get that, to take that treatment. It is actually only for people who have the SOD1 gene. So we talked earlier about how 10% of ALS cases, they are familial. Well, a smaller even percentage of those cases are attached to the SOD1 gene mutation. And so if that mutation is the cause of your ALS, you can take tofersen. And there is so much more to be learned about tofersen, as it is very new to our market. But with both of these new diseases, with both of these new treatments for the ALS disease, our focus is making sure that we can get insurance to cover these treatments, because we do want everyone to experience the potential benefits and hopefully not experience any of these common side effects that I've been kind of mentioning as we've been going through. The very last treatment I want to touch on is Nuedexta. This is different from the others because it is not intended to slow the progression of ALS, but instead it treats pseudobulbar effect, which is a medical condition causing sudden, frequent, uncontrollable crying and or laughing, which really doesn't match how the patient is feeling. So Nuedexta is to treat PBA, pseudobulbar effect, which often accompanies ALS. Once again, there are some side effects. Most commonly, they could be diarrhea, dizziness, cough, vomiting, weakness. But again, we have plenty of patients who do not experience those side effects and do benefit from Nuedexta. So really quickly, I am about to talk about caregiving, and that's a real bulk of this presentation because it is such a unique experience when you are dealing with ALS. But I want to first open things up for questions. We've talked about ALS statistics, diagnosis, symptoms, and some treatments that are out there. Are there any questions about ALS?
Hi, Shawna, this is Simone. We did have a question come through. For non-familial onset of ALS or the sporadic kind, are there any known causes, such as environment, previous injury, anything else?
So unfortunately, at this point, nothing for sure. What I will say, though, is we have some statistics like if an individual played professional football, they're 4 times more likely to have ALS. If an individual is a veteran, they're 2 times more likely to experience ALS. And because there is so much research happening right now to try to answer that question and try to tell us more about why these sporadic cases happen, there is a registry, a national ALS registry that we do invite all of our patients to register with. And there's a very long, very extensive survey about their experiences in their life, right? So what injuries did they have? What kind of water did they drink growing up? What neighborhood did they live in? So that we can try to figure out those environmental aspects and try to get some patterns out of the experiences that our ALS patients had prior to diagnosis. So hopefully we will have an answer to that question. And with how much research has been happening, really getting our hopes up that we learn more soon, as we've been learning quite a bit with our new treatments. But at this point, nothing we can say with certainty.
Thank you for that, Shawna. Another question that came in, does ALS impact women or men more? Or do we know?
There is a slightly higher rate of men experiencing it. But with that being said, we're not exactly sure why.
Okay. And along those lines, another question about incidence of ALS. This person is wondering if there's any data to suggest that COVID might have an impact on the development of ALS.
Not at this point. And, COVID being such a recent development, I wouldn't be surprised if we do hear more about that one way or the other in the next few years. But at this point, there's been no information released about any linkage between COVID and ALS.
Okay. And then finally, we have a question about who would you go and visit first if you're noticing some of the symptoms that you described? Would you talk to a primary care doctor or a neurologist?
Well, unfortunately, with many insurances, you do have to go to a primary care physician to get your referral to the specialist, but absolutely a neurologist is the right person to be talking to. ALS is so rare that there are even neurologists who can go their whole career without seeing ALS. So with that being said, there's a lot of primary care providers who are not experienced in ALS and who might not be able to see these signs early on. And that's why we always recommend going to a neurologist. And even a step past that, I'll talk a little bit later about multidisciplinary ALS clinics. But once someone is diagnosed by a neurologist, gets a second opinion from another neurologist, we then recommend they get involved in an ALS multidisciplinary clinic. So they're working with a neurologist and a multidisciplinary team of medical professionals who do have a lot of experience with ALS, because so many people don't, because it is such a rare disease.
Okay. So one last follow-up question, Shawna, and then we'll move to the next section. This individual is asking if she should pursue a second opinion because the neurologist that she sees believes that the symptoms that she's identified are more related to memory issues, but this neurologist hasn't really even suggested anything to do with ALS.
Well, I am not a medical professional and cannot give clinical advice, but I will say that in general, we do always recommend getting a second opinion. Not all neurologists are the same, and they aren't all going to see the same symptoms. Now, of course, once you do get a second opinion, if they agree, you can be so much more confident. So when in doubt, we do recommend that.
Thank you, Shawna.
Of course. Thank you, everyone, for your questions. I wish we had more answers about ALS on a grander scale. Hopefully that's coming with all the research and all the money being raised right now. But next, I'm going to talk about caregiving for people with ALS, because it is such a unique experience. There are 3 areas I'm going to focus on, which all family caregivers do deal with: advanced planning, care coordination, and support with activities of daily living. But we're going to kind of look at how with ALS things might be a little bit different. For example, with advanced planning. With ALS, we want people to plan as early as possible because we don't know how someone's disease will progress, right? Some people, like I said, will progress very slowly and they'll outlive the 2 to 5 year estimate for lifespan after diagnosis. And some people will progress very quickly and they will not make it to that average 2 to 5 year lifespan. So we always want people to fill out a POLST. That's a set of physician orders that address a limited number of very critical medical decisions. For example, do you want to have CPR, or maybe you don't want to be resuscitated? What are your treatment orders for a hospital, for the ICU? Do you want to be on a breathing machine? And if so, with your POLST, you can specify how long would you want to be on that breathing machine. And then medically assisted nutrition. Are you open to having a feeding tube? Is that something that you would like them to do when you are in an emergency situation, or would you rather not? Unfortunately, when people don't have a POLST, an emergency may happen and the doctors will act in the way that they see appropriate, and someone may wake up with a feeding tube if they didn't want one, or with maybe even a tracheotomy that they did not choose. So another thing that we always recommend is the advance directive, appointing someone else to make your healthcare decisions when you lose the capacity or the capability. An advance directive does not replace a POLST, but we do suggest that people have both. And we here at the ALS Association, we have 5 wishes, and we often give that to people to fill out. 5 wishes is a much more user-friendly and all-encompassing document that includes the medical power of attorney, right? Your advance directive. It includes instructions about medical treatments, which should also be in your POLST, of course. But it also, in addition, will talk about how you want your comfort care, how you want people to treat you, how you want your end of life affairs to be arranged. You can even specify what you want for memorial services. So these are just some different options for doing some of this, making some of the same decisions. And we do, of course, always recommend you have that POLST in place right away. But in addition, do your advance directive. In addition, look at that 5 wishes packet and do so as soon as possible, because we don't know how each person with ALS is going to progress. Every case is unique. And then, of course, part of this advanced planning is not only your power of attorney for your medical affairs, but your financial power of attorney, who's going to manage your property, who's going to help you get your orders and your affairs in order, and then end of life planning. So involved in getting your affairs in order, you're going to want to update your insurance policies, life insurance, long-term care insurance. Make sure your will and your living trust are updated. Make sure your beneficiaries are accurate and that you have, secondary beneficiaries even. But the reason I bring all of this up is because it really does fall on the family caregiver as well to support with this process. Depending on how someone is affected by ALS initially, they may or may not have the use of their hands. They may or may not be able to transport themselves, to meet with a financial planner, to go to the appointments with the doctor, and to work with them on the POLST. So it's just so important that our family caregivers are supporting the person with ALS in getting all of this arranged as soon as possible, physically supporting them, and then emotionally supporting them, because none of this is easy to think about. None of this is easy to work on, especially if the diagnosis is fresh, which we want this to be done early on for so many reasons. So advanced planning is a big aspect of this diagnosis. And then we get into care coordination, because nobody on their own, especially when dealing with ALS and these progressive symptoms, can coordinate care on their own. we need help from the family caregiver in, first of all, applying to Medicare, because regardless of age, if you are 20, 30, or 40 and you're being diagnosed with ALS, if you have paid into the system, you are eligible for Medicare without that 6-month waiting period. Not all ALS patients have the time to wait. So that's great. You can apply right away. It's not easy to apply. Generally, it will be beneficial to have some help, especially if the patient has no dexterity in their hands to type, to write. And then, of course, support, just keeping track of claims and payments with insurance, support in figuring out what durable medical equipment does your insurance cover. What can you get through insurance and what's going to have to be private pay? Maybe you'll be reaching out to the ALS Association for support with some of the things that are not covered by insurance but are private pay. And we will talk about how we can support with different aspects of that. I talked earlier about the multidisciplinary ALS clinic. Those clinic visits can be about 4 to 5 hours long. And of course, in between your clinic visits, which are generally 4 times a year, they're about every 3 months for most people. They can be more frequent, they can be less frequent depending on progression. But between those clinic visits, you're also going to have other appointments with specialists. And we encourage people with ALS to get involved in clinical trials if they are accepted. We are fortunate in the greater Sacramento area to be so close to San Francisco. If you're in Southern California, your closest area is going to be Los Angeles, where they might have some of these clinical trials that you can get involved in. If you are accepted into a clinical trial, there is a lot of travel to and from, depending on how far you are, to and from that big city where the trial is happening. And with all of these care coordination topics, transportation is something to consider. If somebody is early in their progression with ALS, they may be able to drive themselves. But for the vast majority, driving is no longer safe. And at some point, when an ALS patient is in a power wheelchair, they may need accessible transportation. So at that point, you need a wheelchair accessible van, or a wheelchair accessible transportation service, or a paratransit, although paratransit won't take you all the way to that clinical trial if you're not near San Francisco. It is an important aspect, having that family caregiver there to make sure that their loved one can get to and from these appointments, these clinic visits, and these clinical trials. And then managing medication. We talked about those treatments earlier. And I talked about how for some of them, specifically for Radicava, you're 14 days on, 14 days off. Then you're 10 days on, 14 days off. And managing that is quite a bit of work, especially if you're supposed to start your next cycle and the medication hasn't come in the mail yet. Right now, we need to work with insurance. Now we need to work with the multidisciplinary clinic team. We need to make sure that we have the medication when it's needed for those cycles. Care Connection. We actually have a program with ALS Association where we have an online tool that can help coordinate support with tasks from helpful family members, friends, neighbors, community members that you're connected through to, maybe through church or through school or something along those lines. But my point of putting this in is that even outside of coordinating the care of the person who has ALS, you may be needing to coordinate the care of household tasks, laundry, grocery shopping, caring for a pet, caring for children. As we are seeing people get diagnosed in their 40s, they may still have children in the house, especially if they're being diagnosed early in their 30s. So having that support from your entire community is amazing. Still, you're going to need someone to help organize those people who want to help to actually be doing the tasks that need to be done around the house. And then mental health support. Of course, as I spoke earlier, there's transportation of the patient to and from mental health services and support groups. Fortunately, now, since COVID, we have a lot more access to virtual services through Zoom. We offer support groups virtually through Zoom with the ALS Association. I know plenty of others, helpful agencies do the same. With that being said, if a person does not have dexterity in their hands, they're going to need the help of their family caregiver to log them into Zoom. They're going to need help of the family caregiver to put them on mute, take them off mute, if it's a support group where that is required. And then I think this is sometimes forgotten about, but with mental health, we also want to maintain social connections. There is something so isolating about any chronic illness, let alone one that we know is first of all fatal and second of all progressive. So when you're first diagnosed, you might still be able to go to lunch with friends easily, and a few months in, it might be so much more difficult to leave the house. Just the effort in maintaining those social connections and being able to see family and friends is going to increase as the symptoms progress. So that really does fall on the family caregiver to make sure that their loved one is still able to connect with their friends and family, whether it's in person, over Zoom, over phone calls. And then I put transportation at the bottom because that is true for all of this. Accessible transportation for anyone in a power wheelchair, or even before that phase when someone's no longer able to drive themselves. Really quickly, we have one more aspect of caregiving to talk about, and then we're going to go to questions. So, activities of daily living. Because this disease is progressive, the person's going to need increasing intensity of care. Different tools are going to be needed throughout the progression of ALS. The caregiver will be supporting with activities of daily living, but hopefully utilizing equipment to help them in doing that. I could do an entire presentation on equipment. Actually, I often do for for people with ALS, for their caregivers, but I'm just putting some pictures on these slides to show you there are tools out there to help somebody as they're losing dexterity and strength in their hands, to help them feed themselves, dress themselves, things of that nature. But you have to imagine that initially, someone might be able to utilize some of these built-up utensils and be able to utilize plate guards to feed themselves their own meals. And at some point, that ability will no longer be there. The capabilities are going to be reducing as the muscles atrophy, and the role of the caregiver in all of these daily activities, from feeding to toileting to dressing, bathing, the caregiver's role is going to increase consistently. And the role of equipment is going to need to increase as well. The ALS patient will initially use maybe a walker for mobility when they start having some weakness, a transport wheelchair, and then at some point move to a small power wheelchair or a large one. But regardless, at some point they will need that large power wheelchair that's about 400 pounds, that has all the bells and whistles. And all along the way, it's important that the family caregiver is staying ahead of that mobility need. If someone's using a walker far longer than that is safe, they're more likely to fall. So it is very important that they're transitioning into that transport wheelchair when it's appropriate for their safety. And the same is true for getting into the power wheelchair as well. And those larger power wheelchairs, they need to be ordered from insurance with quite a bit of time, because they can take anywhere from 6 to 8 weeks to 6 to 8 months. So again, a lot of the caregivers staying ahead of the progression of this disease. The caregiver will also need to transfer their loved one, and they need to utilize equipment in doing that so they don't hurt themselves. Early on, it may be using something small like a gait belt, a pivot disc, or a transfer board. Later on, they may be using an electric sit to stand, an electric patient lift. So again, as their loved one's muscles atrophy more, as the progression of the disease continues, the level of equipment they're going to need is going to go from small, low-tech devices to much larger, high-tech devices that will also need some training on. As we've talked about, they may need help in the bathroom, in toileting, in bathing, and we know the bathroom is the most dangerous place in the house. So equipment can help. What may start out as a toilet seat riser may be eventually a power toilet seat lift, a rolling commode chair. And we always recommend bidets because we want people to maintain that independence as long as they can. And then with the shower and the tub, we really want to make sure people have the equipment to get in and out of the shower or tub safely. And then while they are being bathed, to be able to recline, to be able to get truly clean. This is all on the caregiver. And it is a lot of work, especially if the caregiver is physically much smaller than the care receiver. But that's why it's so important to have the right equipment and the right support, maybe even from a professional caregiver, if that's what makes it safe. And then, of course, equipment will be needed in the bedroom, whether that's a bed rail, a hospital table, wedge cushion, alternating pressure mattress topper so that we don't get any bed sores, and then eventually a hospital bed, because we want to make sure that the respiratory system is getting as much support as possible. So often having that head raised is going to be much less stress on someone's breathing. And the last little area of activities of daily living I'm going to talk about are quite specific to ALS. Number one is communication. ALS patients will eventually lose the ability to talk. So early on, when their voice is quiet, they may just need a voice amplifier. But later on, there are some low-tech options like a letter board, a writing board. And there are also some high-tech options like a speech generating device where they can use eye gaze, they can use their eyeballs to actually type out what they want to say. And the voice that comes out of the device may be robotic, or it may be their own voice if they engaged in voice banking or message banking before they lost their ability to speak. But all of these things are going to require the support of the family caregiver, where the family caregiver is helping them to do the voice banking and message banking, helping them to calibrate the eye gaze, helping them to set up these devices, or helping to translate the communication from a letter board. It is going to be so important that family caregiver is there to help every step of the way. And the other thing that is very necessary is that the family caregiver can help with respiratory equipment. Non-invasive ventilation, maybe from a CPAP, a BiPAP, Trilogy. There's going to be a cough assist and a suction machine. And it's important that with all of these steps, the family caregiver supports with the setup and utilization. And there's also invasive ventilation, which involves a tracheostomy tube. And at that point, the patient will need support around the clock. So this is just a little look at the activities of daily living and how much the caregiver is needed for all aspects of that day, from waking up in the morning to going to bed at night and everything in between. But how, as the disease progresses, the caregiver's role will inevitably increase. Any questions? This was a big section. This was our biggest section. So what questions are out there about being an ALS caregiver?
Hi, Shawna, this is Simone again. We do have a couple of questions for you here. The first question is, can ALS patients qualify for hospice care?
Absolutely, if they are within 6 months of what is predicted to be their end of life. That is all determined by their clinic doctors. So of course, with hospice care, they would need to be referred. They would need to get that referral from their primary care provider or from their neurologist or clinic team.
Okay, thank you. The next question is, can a diagnosis of ALS in a working age person automatically qualify them for permanent disability?
Yes, it will qualify them for SSDI, absolutely. And additionally for Medicare insurance, which is so important.
Great. What does someone with, this is kind of a tough one. What does someone with ALS do if they don't have anyone willing to act as a family caregiver? Is the multidisciplinary clinic able to provide support with caregiving duties?
That is very tough. We do see it happen from time to time, and it's devastating in the sense that insurance does not cover caregiving. So, if you need someone in your house caring for you, if you're on Medi-Cal, IHSS can support with that. If you maybe have long-term care insurance, that's one way to pay for caregiver support. If you're a veteran, the VA can offer some support with that. But for the large majority of people, having a caregiver in the home is going to be private pay, which is not cheap. And as far as what the clinic can do and what we can do as the ALS Association, it's a lot of providing resources, trying to connect people with grants and connecting people with, with people in their community that can support through things like Care Connection. But it is extraordinarily tough to go through this alone and without someone, a family member, a friend helping navigate. That is generally how it feels, like going through this kind of alone.
Thank you for that. The next question, how much of the specialized equipment, except for communication, is covered by insurance? And if
Great.
it's not covered by insurance, are there other sources, grants available? Two-parter.
Great question. Yes. So most of this, it depends on the insurance is the truth of it, because some insurance plans are great and they cover all the DME. Every once in a while, we see plans where actually no DME or durable medical equipment is covered. It very much depends on the insurance plan. For the most part, these are covered. Even the communication devices, for the most part, are covered. For example, the large power wheelchairs that weigh about 400 pounds, they can cost anywhere from $30,000 to $50,000. What's great is that Medicare covers one power wheelchair device, one powered mobility device every 5 years. So as long as you have not used that benefit, it will be covered. And as long as you have Medicare, right? So again, we're going back to what plan are you on? But when things are not covered, because that does happen, there are gaps. There are gaps for many people. They all lie in different places. The ALS Association does our best to fill those gaps. If you cannot get something through insurance, we hope that we have it here in our equipment loan program. I'll talk a little bit more about that later, but for example, if someone's waiting for their power wheelchair that was covered by insurance, but it's going to take maybe 6 months that they don't have, we have some power wheelchairs here that we will lend out with the support of an assistive technology professional. And if you don't have that benefit, and if you aren't going to be able to get a power wheelchair, then we will just lend you one of ours, again, for as long as you need it. Everything that we lend out is for as long as the person needs it. We can do that with everything except for respiratory equipment, because respiratory equipment requires a respiratory therapist, but
Yes.
pretty much everything else we've discussed today, we lend out if your insurance won't cover it. And if for some reason we don't have it at the time that you need it, we do have a grant program you can apply for to buy it on your own.
Excellent. The next question, this person is wondering what the major difference is between Parkinson's and ALS. So kind of going back to the first part a little bit here.
I wish I were more knowledgeable on Parkinson's. I know there are quite a few differences. One similarity is that they both have experiences being tied kind of closely to FTD, frontotemporal degeneration. There are definitely some similarities, but there are quite a few differences as well. They have different clinics that they're going to go to. At ALS clinic, we don't see anyone with Parkinson's because the diseases are that different. I wish I knew more about Parkinson's, and actually I partner with someone who works with Parkinson's in this community so that I can pass people along when that is their diagnosis. And when they don't fit in at the ALS Association, we send them to the appropriate community resources.
Thank you, Shawna. Uh, Another question, this person is referencing their care receiver specifically,
Yeah.
and reports that, he's that the family's not sure kind of what's happening with him, whether it's cognitive or Parkinson's, but she's wondering if she should take him to someone to get a diagnosis, or if it's possible to have palliative care or hospice come into the home and determine this.
So with those symptoms, we would definitely recommend going to a neurologist to get a diagnosis. As much as palliative care and hospice care are both very helpful services, they generally don't diagnose. They can give suggestions, they can kind of give their opinions and their 2 cents, but it won't be a true diagnosis. And then once someone is diagnosed, yes, we always recommend having palliative care come in for support once that chronic or terminal illness has been diagnosed, and then of course hospice when appropriate in the last 6 months.
Thank you, Shawna. 2 more questions. And this question goes back to the first part as well. What are the similarities between Lewy body dementia and ALS?
So yeah, there are, I understand how some people can see some of those symptoms being similar, but they are from completely different causes. Lewy body, I wish I knew more about Lewy body. I've done some brief research that is more cognitive. There are physical symptoms, but it's not the same process of nerve degeneration and muscle atrophy. And there are cognitive symptoms of both, but ALS has far fewer cognitive symptoms, and not everyone with ALS even ever experiences any cognitive symptoms from the disease.
Thank you. Last question here. If care needs of the person with ALS exceed those that a family caregiver is able to provide, are there facilities that will take ALS patients?
This is a really good question. Yes. So it definitely depends on where the person is in their progression. Early on in their progression, an assisted living facility might be appropriate. But once enough care is needed, which usually when a family caregiver can't do it alone, we're looking at someone who needs more care, then we might be looking at a board-in care. And at a board-in care, some of them allow feeding tubes, some of them don't. We always refer people to some partner agencies that we have that really know the ins and outs of each and every board-in care to know which one's appropriate. And then a level past that would be a skilled nursing facility. Skilled nursing facility is going to be needed if the person does have a tracheostomy tube, then they would need skilled nursing, because that does need such a high level of care. But so there are a variety of residential options. And of course, there are also increasingly supportive in-home options, whether you're doing companion care, personal care, in-home skilled nursing. So it's kind of a continuum of support for in the house and for at residential facilities, where an ALS patient could get support in either setting.
Thank you. Just for the sake of time, we're going to move on, but there may be more questions that come into the chat, and we'll try to circle back to those as we get toward the end. Thanks, everybody.
Sounds good. I will try to be quick here. The ALS Association, we've been established since 1985. We are the only national nonprofit fighting ALS on every front. So we focus on coordinating multidisciplinary care through those ALS clinics. We work on fostering government partnerships. We are not only focused on making sure that all ALS patients are receiving the best care possible and supportive services, but also that research is happening at every level. We're making sure we've got money going to research, and that advocacy is being addressed, because we want to make sure that even though ALS is a rare disease, that we are not being forgotten about in the state and federal arenas. It's so important that we have a voice for this community as laws are being made and passed. Our vision is to create a world without ALS. Our mission is to discover treatments and a cure, to serve and advocate for and to empower people affected by ALS to live their lives to the fullest. Right now, our goal is to make ALS a livable disease. At the beginning of this presentation, I said ALS was always fatal. We're hoping that in a few years, when I give this presentation, that won't be the case. I've already talked about some of these programs. So again, I'll try to be quick here. Number one, we register all ALS patients who want to be registered so they get timely and comprehensive information on, first of all, where to begin with their diagnosis, but then where they can get support as their disease progresses. What somebody needs the day they're diagnosed is very different than what they need 6 months later. We have our equipment loan program. We've talked a lot about that. But it's one of our most utilized programs to make sure that everybody has the durable medical equipment, the assistive technology that they need to live the best quality of life they possibly can, even if their insurance will not cover it. We do have a remote language interpretation program because ALS affects people of all backgrounds. We want to make sure that no matter what language an individual speaks, they are getting the support needed. I love our virtual home modification program. It is amazing. It provides an assessment of a person's home, focusing on the safety of entry and exit of that home, mobility around the house, transferring safely so the caregiver and the care recipient don't get hurt, what the bathroom access and safety looks like, and the ability to call for assistance, which gets increasingly difficult as someone loses their ability to speak and maybe even loses their ability to, press an alarm button. But this virtual home modification program helps people to get that assessment of their house and then to make the necessary modifications, get the necessary equipment at the lowest price possible, because we do not want people pouring tens of thousands of dollars into their house just to be able to stay in it, to live in it. And we know that unfortunately, this disease is always fatal. So we don't want people to spend a ton of money changing their house when their loved one who needs those modifications may not even be able to enjoy those modifications for a very long period of time. We have a support group program providing non-therapeutic, regularly scheduled opportunities for people living with ALS, their family members, friends, and caregivers to network, to share information, to ask questions. We have the Quality of Life Grant Program, which will provide financial grants to help cover expenses associated with ALS. We see it most frequently used for equipment, for home modification, for respite care, and for transportation. The Clinical Care Program utilizes the multidisciplinary clinics to really collaborate with all of those incredible providers and make sure that our ALS patients are utilizing these clinic teams, they are involved, and therefore their quality of life is improving because of the support they get from the multidisciplinary clinic teams. We've got a volunteer program to benefit the community members that want to help, but also to benefit people with ALS who need the support. And then our Caregiver Support Program. This is the program that I manage, and this program is brand new, less than a year old. So I want to talk a little bit about what we do here. I provide caregiver consultations to discuss the planning and increased preparedness for future progression of this disease. You can imagine getting this diagnosis and then trying to figure out what to do next, and then trying to figure out what you'll need to do in 6 months and in 12 months. And so these caregiver consultations really give people so much more information and this feeling of preparedness and so many resources to utilize. Of course, I support family caregivers in getting the appropriate equipment they need, likely through our loan program, and then also information about palliative and hospice care, providing families with local directories for caregiving agencies. I always refer people to Del Oro Caregiver Resource Center. Making sure they have information about accessible transportation, residential facilities, financial assistance, mental health support. We've got some partnerships with some counseling agencies. And then, of course, making sure that they can access these community resources. And if there are any roadblocks, helping them to get in touch with the right people. I support families with creating a care connection calendar to utilize their social network to provide support around the home. We offer age-appropriate literature because we are seeing children in the homes of people being diagnosed with ALS, and it is so important that those children are supported as well. We facilitate separate support groups for caregivers and for people who have experienced loss due to ALS so that they can really get the most out of these support groups. Sometimes they don't feel comfortable saying what they need to say in front of people who are currently experiencing the illness. So we do want those separate groups. And then I support families in donating equipment to us, to another ALS patient, to another organization when their loved one has passed and they don't want the equipment in their house or in their garage. They want to get rid of it right now. We're there to help them with that step as well. So I have some of my information up here. I know Simone will likely email you guys my information later so you can ask me any follow-up questions you need. Simone, I know we're at time, but I can stay for another few minutes if anyone has any questions.
Thank you so much, Shawna. I just want to acknowledge my sincere gratitude for you're taking the time today to provide this comprehensive understanding of ALS and really couch it in terms of what it looks like for the caregiver as well. So thank you so much for being with us today. We did have one final question that came through.
Yeah.
And this individual is wondering if genetic testing is necessary to diagnose ALS.
It is not. It is not. So only 10% of people with ALS even inherited it through a mutated gene. So unfortunately, genetic testing won't even help us to diagnose it in every case. And that unfortunately is also why we can't say for sure if someone has it or not. We can't just pull their DNA and say, yep, this is definitely ALS. In some cases, people will want to get a genetic test if multiple people in their family have had ALS. They can get that genetic testing to see if they have the mutated gene. If they do have that gene, then there is a very high likelihood they will express that gene at some point in their life in the form of ALS. But again, only 10% of cases are passed through family genetically.
Thank you so much. Shawna, I just want to highlight that you are getting love in the chat. And we are going to conclude today's program. For those of you joining us on the call, if you have not heard of Del Oro Caregiver Resource Center, please do check us out. Today's program was made possible by a collaboration between Del Oro and the ALS Association. And we are here to support caregivers. So please give us a call. You can reach us at 916-728-9333 or visit us on our website at www.deloro.org. And you can see on the screen here some of the services we provide and our catchment area. With that, one more big thank you to Shawna. We appreciate you, and I wish everyone a wonderful rest of your day. You will see a survey, a feedback survey on your way out. Please take a minute to fill this out. This is important to both of our agencies, allows us to continue these kinds of collaborations, and it's just good for us to figure out how to what kinds of content we should offer in the future and how best to deliver it, what formats we should deliver it. So thank you again. We'll see you all next time.
Thank you.